So, candidate one, are you able to see the screen?
Yes.
Yeah, sure. Okay, your
It's a
timer.
little hazy. Is that how it is?
Sorry?
It's a little hazy.
Uh,
Or maybe it's from my end. It's fine. Okay.
yeah.
It should get better with time though. Yeah, I
Oh,
mean, maybe it loads up a little late.
all right.
Yeah, you can start.
Okay, so I'm presented with a frontal chest radiograph of a skeletally mature patient. I can see in the left apex, there is a well-defined opacity. The inferior border of the opacity seems well-defined. However, I don't appreciate the superior border entirely. The left apex appears mildly hazy as compared to the right side. I'm just looking at the underlying ribs and clavicle. There seems to be no obvious evidence of erosion. Looking at the rest of the lung fields, they appear unremarkable. The bilateral costophrenic angles appear free. The cardia appears normal in size. So the only abnormality that I see is this well-defined opacity in the left apex. I would want to know the history of the patient. If the patient is having any symptoms of fever or raised inflammatory markers, I would think this in terms of a consolidatory patch within the left apex. I can, just looking at, having a closer look at it, I can see there is a lucency within this opacity. So I'm concerned if this could be a cavitatory lesion. Um, yeah, there is no overlying rib destruction as such. Now I'm concerned if this could be an consolidatory mass with cavity. In an adult patient with this presentation, this could either be infective or this could be something more sinister. I would convey these findings to the referring clinician, see if there are any previous radiographs available to make comparison if this lesion was present before and if there's any signs of progression or if this is a stable appearing lesion. I would also want to know the clinical history of the patient. If there are raised inflammatory markers, this could be an infective focus. If it's an elderly patient, this is concerning, and I would want to go ahead with the CCT of the thorax for further evaluation. Thank you.
So, what are your differentials from the X-ray?
My first differential would be an consolidatory focus, an infective focus with some areas of cavitation in, centrally. And my second differential would be that of a more sinister, probably a bronchogenic carcinoma, since it's in the apex of the lung as well.
If I were to say it's metastasis, what are your differentials?
A single metastasis into the lung, I would be thinking of a colon primary,
Okay.
or
You're talking
yes.
about a cavitating lung metastasis, is it?
Yes, if it's a cavitating lung metastasis, I would think of a squamous cell primary. Or if it's a female patient, I would also
From?
from the head and neck.
Okay.
For female patients, I would think of a cervical malignancy.
Okay.
They could give rise to cavitating mets.
Okay. Anything else? Any other malignancies that you can think about? If I were to say that the patient has the hematuria.
Yes, renal cell carcinomas also give solitary metastasis to the lung. However, I'm not sure if they cavitate, but yes, solitary metastasis to lung can be from an RCC primary.
Which variant of bladder malignancies can present with cavitating metastasis?
Squamous cell carcinomas of the bladder, probably in a schistosomiasis infection. Post that, if we have a squamous cell carcinoma of the bladder.
Okay. So anything else? If I were to say that this patient has a long-standing history of recurrent sinusitis.
Recurrent sinusitis, then I would be thinking of Wegener's as well. The Wegener's also can produce nodules within the lungs. However, it would be bilateral, unlikely to be unilateral, and such a well-defined nodule. But if the patient is having sinusitis history, I would think of Wegener's granulomatosis as well.
If the patient is having any history of sepsis,
then a septic emboli is possible. However, that would be more peripheral
okay.
and bilateral.
And
That would also
which lobe do you think septic emboli would present
lower
in?
lobes. Lower lobes.
So do you think this could be septic emboli?
No,
Okay, okay. So
unlikely.
I have the CT for the same. You can ask for control and scroll.
Okay.
Yeah, go ahead.
Okay. So these are the axial CT sections of the same patient in the lung window. I can see, I'll just scroll through the images before making my statement. Okay, so the main abnormality that I see is again within the left upper lobe. I can see there is a well-defined cavitating lesion. I'm just going to come to it. Yes, a well-defined cavitatory lesion. It's having thick walls. It's abutting the fissure. There is no other evidence of other cavities within this lung or the contralateral lung. I would want to look at the mediastinal window as well to rule out any lymph nodes. But at this stage, a solitary cavity lesion in the upper lobe of the lung. And in this, I think there are no lymph nodes. This is most likely looking infective. Yeah, in the absence of lymphadenopathy, I cannot be really sure. So I would convey these findings to the referring clinician. I would raise the possibility of an infective etiology if the patient is having such symptoms. If the patient is having more sinister symptoms like weight loss or loss of appetite, this patient would require further management, probably a CT-guided biopsy for confirmation of this lesion, and a lung MDT discussion would be required for further management. Thank you.
This is your next case.
Okay, I'm provided with a nuclear medicine study of the whole body. I can see there is uptake within bilateral kidneys. Thinking this to be a technetium 99 MDP scan. I'm not able to see any uptake within the ribs or the long bones. There is mild uptake in bilateral distal ends of the femur. That could be osteoarthritic changes. I can also see mild uptake within the iliac bones bilaterally. There is a small uptake that I see in the left-sided rib. Is this the same patient?
Yes, no, it's a different patient.
Okay. So I see a small uptake within the apex of the left hemithorax.
You can ignore that. You can ignore that.
Okay.
So what are your positive findings so far?
So far, I can see that there is an asymmetrical uptake within the kidney. The
Okay.
right kidney shows mildly increased uptake.
I can help you with the posterior view. Yeah.
Okay. I'm not able to pick up any finding.
So you did say that there is uptake predominantly in the kidneys, right?
Yes, bilaterally.
Okay, so what do you think? What are the possible causes for this appearance?
So free technetium can cause, if there's free technetium within the body, I think it can cause an uptake within the kidneys bilaterally. If there's an increased dose of technetium, or it could.
If I were to say that this patient complains of recurrent bone pain.
Okay. So with an increased uptake, since there is recurrent bone pain, if it's in an old age patient, I would think of multiple myeloma, which does not get picked up on a technetium 99 NDP scan. So I'm not sure if this is a case of multiple myeloma.
No problem. Yeah.
Not really.
Is there anything else that you can add?
No.
Okay, no problem. Let's go to the next case.
Yeah.
You have to identify what has been done in this case, in this mammogram? What is the marker used? And for why is that marker used? What is the name
Okay.
of the marker and why is the marker used?
Is the marker this one?
You can click and you can just click.
This.
Yeah, correct. Yeah.
Okay. Um, I'm assuming that this is in the inner quadrant, so this
Guys, 5 minutes left.
is it post a biopsy or an FNAC of lesion, and then a marker has been placed to identify it during imaging? I'm not sure.
You're asking me or you're telling me?
I am telling. I'm not sure.
Okay, yeah. You can tell me whatever you feel is right.
So I think that there has been a procedure in this region, and a marker has been placed to identify the region during imaging to correlate findings.
What would you like to do next?
I would want to see the contralateral breast if the same marker is
That
present.
was normal. No, it was only present in this breast. And the physician wants to know, is this concerning or not?
Uh,
Okay. Is there anything else you want to add?
no, there's a slight asymmetry in the breast tissue in the lateral quadrant as compared to the medial quadrant.
Okay. Sure. Let's go to the next case.
Okay.
You can, you can scroll and just let me know what you think.
So these are axial MRI sections, T1 weighted. I'm just going to scroll through the images. So I can see that there is an heterogeneous intensity lesion noted within the left cerebellar hemisphere. There's no obvious, there's mild compression over the fourth ventricle. The fourth ventricle seems to be displaced towards the right-hand side, and I think there is mild upstream dilatation of the ventricles as well. I don't see any other lesion. I would want to check these this intensity in other sequences as well before.
Which sequence do you want to see?
Can I see post-contrast T1 images?
Sure. Here you go.
So on post-contrast images, this lesion seems to be enhancing. There are some areas of non-enhancing within non-enhancing regions within the center. So in the cerebellum, an enhancing lesion, if this is an elderly patient, I would be concerned if this is an metastatic deposit. There are no other lesions within the rest of the brain. There is mild hydrocephalus, obstructive hydrocephalus also due to the mass effect. So I would immediately pick up the call and inform the referring clinicians regarding the hydrocephalus. This needs to be decompressed immediately. And this case should be referred to the neuro-oncology MDT for further discussion, because there could be a possibility of an hemorrhagic, a metastasis in this case. And I would also do a complete staging of the chest and abdomen to find the primary in this case. Thank you.
If I were to tell you that this patient had an incidental swelling in the testis, and that an ultrasound was done and it was completely benign, would that make you think of any other differential?
Testis ultrasound was benign.
Yeah, there was a lesion in the testis, but it was benign. But I'm telling you that this is related to the lesion that you're seeing currently in the brain.
I'm thinking of syndromic associations.
Is there any other sequence you would like to see? Or you would like to just stick with metastasis and go ahead? Please mute everybody else. Yeah, please go ahead.
Can I see T? No, T. Can I see diffusion? Okay.
What are you
So
thinking about? What are you thinking? What is running in your mind right now?
So since the testis lesion is benign, I'm thinking if there are any syndromic associations.
What syndrome do
But
you think of? What syndrome are you thinking about?
I there's only one syndrome that I know about in the cerebellum right now. That is the Lermite-Duclos syndrome. But I don't think it has any association with testicular masses.
No problem. Yeah, your time is up. Thank you.
Okay. Thank you.
Yeah. Dave, I'll take. You can take over.
Okay, okay.
One sec, Dave. I'll just. One sec. I'll just. I think. I'll have to give you permission. One sec. Yeah. Go ahead.
Okay, just one moment. All right. I'll just share my screen. Is the screen visible now?
Yes.
Okay. So this is the first case. And this is the patient who's a 55-year-old male patient. And this is his, just quickly stretch it a bit more. This is his chest radiograph. So your
Yes,
time starts now. Yeah.
Okay, I'm presented with the frontal radiograph of a 55-year-old male who's presented with chest pain and dyspnea. I can see that bilateral lung field show diffuse reticular patterns, more so pronounced in the bilateral lower zones. I can also see that there are significant fibrotic parenchymal bands that are seen extending from the mediastinum towards the periphery of the lung, especially in the left lower zone. Bilateral hemidiaphragms appear unremarkable. There's no obvious evidence of pleural effusion. There are no concerning findings like pneumothorax or pneumomediastinum in this case. Quickly looking at the bones, I don't see any sinister lesions within the bones. In this patient who has a history of cough and hemoptysis, I can also see some tubular branching structures noted within the upper lobes of bilateral lungs. These could probably represent bronchiectasis with some peribronchial thickening. So I'm concerned that this could be an interstitial lung disease since the bilateral lobes are involved and predominantly involving the lower lobes as well. I would check previous radiographs of the patient to correlate the findings. And if there is any history available, I would check his previous files as well. I would convey these findings to the referring clinician and probably order for an HRCT of the chest for further evaluation in this case where I'm suspecting an interstitial lung disease.
Why are you suspecting an interstitial lung disease? Can you just summarize once more?
Because there are coarse reticular markings bilaterally, more pronounced in the lower lobes. And I can also see some tubular opacities in the upper lobes, which I'm feeling there could be bronchiectasis as well.
Yeah.
And
Do you see any other findings?
I can see some nodules. Yeah, I can see some well-defined nodules in the left upper and mid zones. And
So what are your review areas when you're looking at a chest X-ray?
I would look at the bones. I would look at the retrocardiac region. Okay. Okay, I think I do see a retrocardiac opacity.
In the light of these new findings, does your diagnosis remain the same or would you make a change?
No, my diagnosis would change. So since I can see a retrocardiac opacity and I can see diffuse reticular shadows with nodular patterns, now I'm thinking in terms of an bronchogenic carcinoma with probably a lymphangitic picture. So I would convey these findings to the referring clinician. A CCT of the thorax should be ordered for this patient, and an immediate discussion in the lung cancer MDT needs to be ordered for. Thank you.
You can take a look at the CT. If you ask for control, I'll give it to you. Here you go. Just click once and start scrolling. It should work. Yeah.
Okay, so I'm provided with the axial section CT scan, plain study of the same patient. I can see in the left lower zone, I can see that there is an ill-defined soft tissue density lesion that is seen in close proximity to the hila. I can also see that there are no obvious vessels passing through this. There's possibility of a bronchial cutoff also seen. Just seeing if I can, there are no obvious evidence of enlarged lymph nodes. Yeah, there is an enlarged lymph node. There are a few enlarged lymph nodes in the paratracheal region and subcarinal region. So in this, I would also see the lung window to see the rest of the
Let go of the mouse. I'll quickly give you the lung window. Here you go. You have control.
Okay. So on the lung window, I can see that there are a few coarse interstitial reticular markings, as well as multiple nodules that are present in bilateral lung fields. Surrounding this lesion, there are few ground glass changes along with some fibrotic bands as well. Considering that this is an elderly patient with an ill-defined mass lesion with multiple nodules within the lung, I'm concerned that this could be a malignant process. I'm quickly just looking at the bones if I can see any evidence of lesions within the bones. I don't see anything in this
Do
scan.
you evaluate the bones in this window?
No. Can I have the bone window?
Yeah, let go of the mouse.
Yeah.
Here you go.
Okay. So looking at the axial sections in the bone window, so I do see that there are a few lytic lesions noted within the blade of the left scapula and few of the posterior ribs on the right side as well. So this confirms my suspicion of an primary lung carcinoma with probably metastatic nodules within bilateral lungs and the possibility of bony metastasis. I would convey these findings to the referring clinician and order for this patient to be sent to the lung cancer MDT discussion. The patient would also require a completion CT of the abdomen and pelvis for staging purposes. Thank you. And
Let go of the
probably
mouse, please. Yeah, you can let go of the mouse. Yeah.
Yeah.
Okay, so this is your second case. This is a 65-year-old male patient who had a history of recent trauma, seizure, and cardiac arrest. Okay, so let me just quickly give you that this was the first initial X-ray, which was found to be normal, but then the patient desaturated quickly, and this was the second X-ray.
Okay. So this is the frontal radiograph of an adult patient who has undergone trauma as well as cardiac arrest. I can see that bilateral lung fields show some patchy airspace opacities. The right hila also appears mildly prominent. I'm just seeing if there are any lines and tubes that I can comment upon. Okay, I can see that there is a left lower lobe collapse evidenced by the sail sign and silhouetting of the left hemidiaphragm. And if I trace the left lower lobe bronchus, I can see an opacity that is present within the left lower lobe bronchus, which could be the reason why the patient has a collapse of the left lower lobe. In looking at this opacity, this seems to be a tooth. And since the patient has had history of trauma, I'm suspecting that there has been a foreign body aspiration of a tooth, which has led to an collapse of the lung. So I would immediately pick up the call and inform the treating physicians regarding this collapse, and an endobronchial there needs to be endobronchial retrieval of this foreign body. And I would convey these findings to the referring clinician. Thank you.
Okay, so here's your next case.
Okay, so these are lateral and frontal projections of the knee joint covering the ankle as well of a skeletally immature child. Can I zoom the image a bit?
Unfortunately, we can't
Okay.
zoom here. But which area do you want to take a look at?
In the frontal projection, I want to look at the metaphysis of the tibia, because I feel like there's slight widening of the metaphyseal of the proximal tibia.
You
And
can ignore
just,
that. You can ignore that.
okay. Looking at the rest of the bones. The distal aspect of the femur on the lateral projection, I'm suspecting there to be a mild angulation. In my routine practice, I would just zoom this image up, because if the patient has come with the history of a fall or knee pain, I would be concerned about this being a metaphyseal corner fracture.
You're talking about the femur, right?
Yes.
Yes. Let me just assure you the femur is normal. Anything else? Does anything else catch your eye? If not, I can. I understand that I can't help you zoom, so I can sort of let me try and see if I can do something to help you.
I don't see the patella.
It hasn't appeared yet, so
Okay.
maybe if now, does that help you a bit?
5 minutes left.
Not able to.
What about now?
I don't see any obvious fracture lines. I'm not able to appreciate fractures. I'm looking at the soft tissue. Soft tissue.
The soft tissue is actually normal. What about now?
I don't know if it's because it's zoomed, but now I can see a lucency through the distal aspect of the tibia. I'm not sure if.
Can you you have control? Can you show me where you think the lucency is? Okay. All right. So there's anything else you see? Okay, no problem. We'll just quickly go to the next case.
Okay.
I'm sorry, I have to readjust this. Nikhil will give her an extra 10 seconds in time, okay? So here you go.
Yeah, sure.
Okay, so your history in the history, it's a palpable mass in the abdomen, and here you go.
Okay. So I'm presented with the frontal projection of the abdomen of a skeletally immature patient. I can see that there is a displacement of bowel loops towards the center of the abdomen, and there seems to be a soft tissue density lesion that is occupying the left side of the abdomen, which is displacing the bowel loops towards the midline. I'm looking at the bones. The vertebra appear unremarkable. Rest of the bones seem normal. No obvious evidence of any fractures or any evidence of avascular necrosis. So in this patient who had a palpable left-sided mass, in this abdomen X-ray also, I can see that there is a soft tissue density lesion that is occupying the left side of the abdomen, extending from the lumbar region all the way up to the iliac levels, which is displacing the bowel loops towards the center. I would convey these findings to the referring clinician in order for a CT scan of the abdomen with contrast for further evaluation of this patient.
in this patient, are there any differentials that you're thinking about while you're ordering the next line of investigation?
So since it's a 4-year-old child, I'm thinking in terms of it could either be a massive splenomegaly, or it
Mm-hmm.
could be something that is arising from the adrenals, like neuroblastoma, or it could
Mm-hmm.
be a lesion from the kidney, like a Wilms tumor, which is more likely for the
You
age of
have
the.
the ultrasounds and you have control, you can scroll.
Okay. So these are the ultrasound images of a 4-year-old child who has a palpable left-sided mass. I'm just going to look quickly at the lesions. So spleen appears normal in size. Left kidney is normal in size. No. Okay, so this is the left. So there is a soft tissue density mass that is occupying the left side of the abdomen. Seems to be arising from the left kidney. It's a homogeneous looking mass with minimal vascularity. There's no obvious evidence of calcifications that I can see within this mass. There is a cystic appearing lesion that is seen within it. So in this 4-year-old child with an renal mass, I'm thinking of a Wilms tumor. Yeah, I'm thinking in terms of a Wilms tumor, and I would convey these findings to the referring clinician, and the patient would still require a cross-sectional imaging for further characterization and to
Have you
check
seen all the
for
images?
bladder appears normal.
Yeah, go ahead, sorry.
I'm trying to see if the vessels are covered in this ultrasound. I'm just looking for any renal vein invasion if it is.
Yeah, time is up.
Yeah.
Yeah, your time
Okay.
is up. Okay,
Okay.
so Nikhil, you want me to go ahead with the
Yeah,
discussion?
please go ahead. Please go ahead.
Okay, cool. So this was case 1, and you focused a bit too much on what you thought were interstitial abnormalities. There probably are some, but they are not the major findings, as you know by now.
Yeah.
This was the major finding, which was a retrocardiac opacity, which you confirmed on CT, along with multiple nodular lesions everywhere in the left side. So when you see this, when you see these nodules and this lesion, you should be thinking about a mass lesion, a lung cancer. And although we didn't go till the contrast images, but that doesn't really add a lot, except that you can describe the heterogeneous enhancement, some necrotic areas, and you did find the rib metastasis as well. So yeah, this is a lung cancer with bony metastasis as well. When you're describing these, especially now, once you have discussed the possibility that it's a lung cancer, always review previous images, or at least talk about reviewing previous images, reviewing previous patient records, because they might be a patient known to the hospital. You don't know at what stage you are being given the case, right? So always make a habit of talking about this. This was the first case. This was the second case. Yeah, you got it straight away. This is an aspiration of a tooth in the left, I think, lower lobe of the bronchus, causing consolidation. There, I didn't take you through the CT, but the CT went on to confirm that, causing this kind of bilateral consolidation. This patient also had some small PEs, but that was just I wanted to take you through some other cases. Those PEs don't really add a lot of value to this particular case, because it was the main cause behind the sudden deterioration was thought to be the aspiration and not the small PEs that you see multiple places. This was I know in real in practice you would have zoomed, but when I showed you this area, I actually wanted to focus on this. There is a small corner tarsal fracture. Once you had identified that, I'm sure you would have explored the possibility of non-accidental injury and, activated the safeguarding team and the whole thing that we talk about when we consider this always order neuroimaging if indicated. If the patient has any brothers or sisters, we bring them in. The whole thing, the whole story that we must go through if we consider non-accidental injury in a patient, right?
Okay.
This was I asked you whether you've seen all the images because after the bladder there was also a right-sided kidney mass. So this was actually a case of bilateral Wilms. So I guess the biggest learning point in this case is, yes, I know that you were trying to look for vascular invasion, and I agree that's something you have to do. But when you see the vascular images, just make sure that the color images, I'm sorry, just make sure that you make a comment that there is increased vascularity, which points to a more vascular aggressive lesion. And make sure you take a look at all the images they have given you, because while you were looking for staging, vascular involvement, the diagnosis is actually bilateral Wilms tumor. So
Yeah.
had you seen all of that, you would have stated that you think there is a bilateral Wilms tumor, and that would have probably translated to a few more points, right?
Yes.
Okay. Other than that, I think you did well, except for that non-accidental injury case, which even after zooming, you failed to identify that. Your speed is good. You come across as confident. You're doing well. Just keep seeing more cases, especially chest X-rays. Just practice seeing more of them, because there are some very typical pathologies that come up. Small apical lesion, small infradiaphragmatic lesion, small retrocardiac opacity. So they always try to give you these cases which challenge you in terms of looking at your review areas. So make sure you practice a lot of them. Okay,
Thank you.
sure. So Nikhil, over to you. I'll just stop sharing. One moment. Here you go.
Yep. Thank you. So I think I'm assuming you're for the September, is it?
Yes, yes.
Yeah. Okay. So I'll just I was just seeing the number of cases that you had seen. So in total, you have covered around 12 cases if you were to cover the entire modalities in each case. Okay,
Okay.
which is a good number. There are a lot of people who say that you shouldn't be really looking at the number of cases and modalities, but as a dictum, it's always good to be in the ballpark of somewhere around about 12. Okay, the more you go, the better. And
Okay.
the good things about you is your approach is good, your fluency of findings and coming to the conclusion, and the fact that I also keep practicing the fact that whenever you end a case, just tell them thank you so that they know that you have ended it and they can
Mm.
ask. So sometimes they do not know if you want to continue or not. Okay. Having
Yeah.
said that, something which I felt was you were repeating a few things more and more often. So the first case that I showed you, I think, was this, right?
Mm.
So when you were describing the X-ray, I think you said I would ask for prior history, and again towards the end you again said I would ask for prior history. You don't have to repeat things, right? Because
Yeah.
you have to be very, when you know that the case is very straightforward, you're seeing a cavitating lesion, you have to just wind it up as soon as possible, right? You know it's an opening case and it's a very easy case, so do not waste time on that. I think you roughly spend 4 minutes on that, which is not essentially required. So again, you should not let the examiners ask you scenarios like, if this patient had sepsis, what would you think? If the patient had sinusitis, what would you think? I think a good approach, like I said in previous sessions, would be give like a conditional differential diagnosis. In this case of a cavitating lesion, if I would be considering if the patient is presenting with sepsis, my thoughts would be along the lines of septic emboli. But the fact that the lesion is seen in the upper lobe makes me think otherwise. I would have expected something along the lines of periphery and lower lobe in case of septic emboli. If it was a case of Wegener's, I would have seen a history of associated sinusitis, and in the upper paranasal sinuses, I would be seeing signs of erosions and whatever fits the picture in whatever differentials you're saying, right? So what it gives a picture is that you have a good base of the differentials and what are you expecting also, right? Rather than letting the examiners ask you, if it was cavitating, what would you think? So if you were saying it's a cavitating lung mass, if I were in your place, I would have said that if I were to consider this as a cavitating lung mets, I would have thought about head and neck tumors like squamous cell carcinomas or urothelial carcinoma of the bladder and all the other differentials you said, rather than me asking you, what are you thinking? If it is this, what are you thinking? So please try to finish off all your differentials in a conditional differential diagnosis way. And otherwise, I think you finished the cases well. You are mentioning about MDTs at all the required points. Okay. So coming to this case, this was a case of Wegener's granulomatosis. But the fact that you cannot completely exclude malignancy, it was good on your part to refer it to the MDT. Okay. Now, this case, I was quite disappointed because I was hoping you would ask for other sequences. And if you had asked for the other sequences, you would have noticed the flow voids within the lesion. And the fact that I already gave you history that the patient had a testicular benign lesion, can you connect the dots and think of any syndromes?
It's in AVM, multiple AVMs or
Uh,
multiple hemangiomas.
no. Actually, I was thinking along the lines of VHL, right? Von Hippel-Lindau. So
Oh,
epididymal cyst is very common with
oh yes. Okay. Okay. Yes.
in the
Yes.
testis. And when you see phlovoids in the background of this, you should think of hemangioblastomas.
Okay.
So I
Oh,
totally understand it's not a very, you can give a set of differentials, but when the examiner is trying to narrow you down with giving you additional clues,
yeah.
please, yeah, it's perfectly fine. It's as long as you do ask for all the modalities and because you just asked for T1 and post contrast and diffusion, of course. If you had asked for T2, I think you might have picked up these flow voids and that might have changed your line of thought. Okay. So
Okay.
coming to this case, sometimes you can be given a lot of markers, and in NHS they use a lot of markers, and those are very specific markers for different conditions. This is called a mold marker. Okay, this is to mark so that the reporting radiologist knows that this lesion is confined to the subcutaneous plane and it is just a mole. It's a benign thing, and just not overcall this as a breast lesion. Okay, so
Oh,
this when you see a circular marker over a lesion, understand that this is a lesion in the subcutaneous plane and it's just a mole. Okay, and this
oh,
needs nothing needs to be done in this case. Okay, now I think another case was this. In this case, this is called a hot kidney sign. Okay, it's a bone scan, and hot kidney sign is, so when you're describing any nuclear scan, if you have no idea what you're thrown at, you just describe that this is a nucleus bone scan where I do not see any uptake in the rest of the bones, and I can see diffuse uptake in bilateral kidneys. Then, however, at this point of time, I'm not able to pick up any differentials that could present with this. And in my routine practice, I would correlate with clinical history and any previous available imaging prior to this to correlate. And I would recommend, if you are thrown with something like this, the only trump card that you can use is probably discuss with a specialist who is specialized in this and take his opinion. Because if you know you're going to burn the case, that you're not going to go anywhere with this, that you can use this trump card only once. Okay, and you can use it probably to the later cases, not in the first two cases. Okay, so this was
okay.
case of hot kidney sign, which is commonly seen with few conditions like acute tubular necrosis, or when you use any nephrotoxic drugs, or when in case of sickle cell anemia, hyperparathyroidism and hypercalcemia. So that is why I gave you history of bone pain if you were thinking along the lines of hyperparathyroidism. Okay,
Oh,
then
okay.
I think that's it. I think
That's it.
yeah, okay. So thank you so
I just wanted to
much.
echo something Nikhil said. Remember the pediatric case where you could not find the metaphyseal fracture? In that case, when you know that the examiner is quiet and you are trying to find something but you can't see it, and instead of saying that, so what I did was I quickly moved on to the next case, but that doesn't always happen in the actual thing. They might just keep staring at you. So you
Mm,
need to know how to wrap it up. So in this case, if you don't know what to do, you can always say, I can't seem to find a pathology, but given that this is a young patient, probably a toddler, I didn't give you a history, but you could always say that I'm worried about a small fracture that I cannot see, I will involve my pediatric radiology consultants to look for any small fractures, because because you're worried about a non-accidental injury or whatever. Just make sure that you are asking for help, because they prioritize safety to see if you're a safe radiologist. And it's entirely possible that we don't know what we're looking at. That happens in radiology all the time. So they want to see how you deal with that situation. So ideally, yes, you should be able to see it, but even if you can't, they won't give you, I don't know how many marks they will give you, but if you ask for help and talk about involving other people so that it can actually be diagnosed, that's better than not doing anything. Okay, so just the kind of what happened to you with the nuclear medicine case.
Okay.
Okay.
Thank you.
Thank you so much. Hope to see you soon again. Okay.
Yes.
Bye-bye.
Thank you.
All the best. Yeah. Candidate 2, are you ready? Dave, should I start?
Yes, I'm ready.
Yeah, go ahead, start. Yeah.
Okay, cool. This is your first case. Your time starts now.
I'm provided with the frontal radiograph of the hand and wrist joint in a skeletally mature patient. I'm going through my checklist. On the first glance, I can see that there is evidence of a fracture involving the distal radius. And also, I can see that there is a fracture involving the styloid process of the ulna. There is no extension of this fracture into the articular surfaces. I can't quite appreciate whether there is dorsal or ventral dislocation of these fracture joints or elements. In my routine practice, I will correlate with the orthogonal views. I'm looking at the carpals to rule out any associated other fractures. I don't see any obvious fracture. I'm looking at carpals. Metacarpals appears normal. I don't see any obvious. I'm coming back to the fracture. I don't see any obvious soft tissue edema, significant soft tissue edema. I don't see any loose bodies. The styloid process of the ulna appears deviated towards the scaphoid. So to conclude, this is the fracture involving the distal radius. I would immediately inform the findings to the clinician. And also request orthogonal beam to look at any other displacement. This patient needs a fracture clinic referral. Other than that, I would also advise for a MRI to rule out any associated ligamental injury in this patient.
Anything else apart from all these findings?
Okay. Okay, I'm going through other images. I can see that there is evidence of abnormality in the scaphoid in the proximal part.
Scaphoid is fine. Scaphoid is fine.
Okay. Trying to look at other areas. Okay. I'm trying to look at the metacarpal joints. I'm suspecting a fracture involving the trapezium and dislocation. I'm not sure. I'll look at orthogonal views to confirm.
Sure, I can give you an orthogonal view.
Okay. This is an oblique view of the same patient. You can see that there is comminuted fracture extending to the articular surfaces, and there is displacement of the fracture fragments. And I'm also suspecting there is a distal radioulnar joint disruption. There is ulnar deviation. Other than that, I'm trying to look at scaphoids. Scaphoid was fine, as you told. Okay, so yes, that's all I can think of in this patient.
Sure, we can go to the next case.
Okay. I'm provided with the nuclear medicine scan. I think this is a technetium MDP bone scan. I can see that it is done in the delayed phase. These are spot images. I think this is a frontal view. I'm trying to look at kidneys. I can see that there is mild excretion in both kidneys. So this is not a super scan. Other than that, I'm trying to look for any abnormal intense focal uptakes in all the bones. I don't see any obvious uptake in the skull. There is mild uptake involving the right side of the mandibular region. I'm suspicious of this. Other than that, there is mild uptake involving the bilateral clavicle lateral aspects and also the humeral heads. Other than that, I'm coming down. I'm looking at the thoracic region where I can see that there is a area of uptake seen in the chest region anteriorly, which I think it could be and in my, okay, if this is a female patient, I would be thinking in terms of a breast carcinoma with lymphangitic uptake. That would explain this. Other than that, I'm looking.
Could you ask for control and show me where do you think the abnormality is?
Okay.
Yeah, go ahead.
Okay. I think this is the abnormality. You see.
Okay. Okay. What do you think it is?
So if it was a female patient, I would be thinking in terms of breast carcinoma with the lymphatic uptake. That would explain this.
Okay.
In my routine practice, I would correlate these findings with
I can give you a closer view.
Okay.
One second. Can you leave the mouse once? Yeah.
Yes.
Yeah, go ahead.
Okay. I'm looking at zoomed up images. I can see that there is uptake. Other than that, if it was not a breast CA or any, I will be thinking in terms of chest wall mass.
What would you like to do next?
Yes. In my routine practice, I would correlate with any previous images available and any plain radiographs available and any previous CT chest available to rule out what this is. Okay, I'm provided with the craniocaudal views. I think it is quite zoomed up. Can you please zoom out?
Zoom out, okay.
Yes.
Yeah, can you leave the mouse once?
Yes, I have not in touched.
Yeah.
I just want to see the labels. Okay, it's fine.
Is it okay now?
It's fine. Okay, I'm given the craniocaudal views of the mammographic studies of the both breast. On the left hand side, there is I think on the right hand side there is left breast and right breast towards the other side. I can see that in the left breast there is fairly dense breast, which is fatty. Other than that, I can see that there is a large area of density in the retroiliac region, extending towards the superior aspect. It is showing significant fibrofatty thickening. And
can you show it to me? Can you show it to me once? Can you click and show?
This is the thickening.
Okay.
This is the lesion I'm suspecting. Okay, I'm looking at the margins. The margins appear speculated, and I'm trying to look at calcifications. In my routine practice, I would look at the magnified view and or with the magnification glass. In the cranial aspect, I can see that there are foci of punctate calcifications. Other than that, I'm trying to look at lymph nodes. I don't see any obvious lymph nodes. I would also look at mediolateral oblique views to look at lymph nodes and chest and pectoral muscles. I can see that there is also evidence of significant skin thickening in the left breast associated with the thickening of the nipple. I don't see any obvious puckering or skin retraction. So I think this is a suspicious mass. I'm giving this a M4. I would convey this finding to the referring clinician, and this patient needs a referral to one-stop breast clinic.
You already said this patient had a PET uptake, and with the background of this lesion, would you still give it only M4?
Okay, with the background of uptake, with lymphadentic uptake, I will be giving it as a M5 lesion. Okay. This patient needs immediate referral to the one-stop breast clinic. Otherwise, patient can be
So
taken for
what
the
is one-stop breast clinic?
one-stop breast clinic is the referral center in the NHS where clinical, histopathological, and radiological examination are done on the same sitting for the immediate diagnosis of the lesion in a female patient.
What is the screening? What is the screening age in NHS?
In the NHS, the updated study says that it is done between 47 to 73 years. However, the previous explanation still says that 50 to 70 years. So it is done every 3 yearly.
Okay. Okay. So what is the current now? What is the current criteria?
Current criteria is 47 to 73 years.
Okay. We'll go to the next case.
Yes.
You can ask for control and scroll.
Okay.
Yeah, you can scroll. Yeah.
Okay.
You have to tell me what study is being done.
Sure. I'm provided with a frontal study of a digital subtraction angiography. I'm going through my given study to assess abnormality. This is a dynamic study.
Yeah.
I can.
5 minutes more. Okay. Yeah. Go ahead.
Okay. Sure. Okay. I can see that in the midline there is a catheter line in situ and contrast being injected. With the DSA study in hand, I'm thinking this could be intercostal artery study to look at any hemorrhage, or this could also be a study of internal mammary artery study, because I can see that there is a contrast blush in the distal aspect and in the precordium. I can't see any obvious.
If I tell you that this patient had history of hemoptysis.
Okay, with the history of hemoptysis, I'll be thinking in terms of any cavitary lesion and which could cause this. With the DSA in hand, I think this could be a case of tuberculosis, wherein I think this could be a case of.
No, I want you to tell me which vessel are we imaging at this point of time?
Yes, I'm trying to assess that. I think this could be a case of bronchial artery hemorrhage because or a pulmonary artery hemorrhage, or I would also thinking of in terms of.
Do you think pulmonary artery caliber fits with this?
No, that is not fitting with the pulmonary artery caliber. So I would be thinking in terms of a bronchial artery.
Okay.
Bleed
I have one
patient.
more image for you. I have one more image for
Sure,
you.
sure.
Scroll and see.
Okay.
What do you
I
think is
this
happening here?
Okay, I think these are the post procedural. I mean, after the embolization, these images are taken.
So, what do you think? If you were to think this is bronchial artery embolization, what particles do you use for embolization?
I'm forgetting the name of it. I think
No problem. No problem.
Yeah.
What should I be concerned about before doing this procedure?
Okay. The main concern should be the patient should not be allergic to this contrast agents and
Anything
the
specific?
patient.
Anything specific?
Okay. I think specific would be patient should be stable.
Anything else?
And that no, I can think of any, but I can think of no pneumothorax and all.
We can go to the next case.
Okay.
Yeah. This patient is presented with altered sensorium. You can scroll.
Sure. I'm present with the axial sections of the non-contrast CT scan of a patient who came with altered sensorium history. On the first scroll, I can see that there is generalized bilateral cerebral white matter edema in prospecting this. Other than that, I'm trying to look at other areas. where okay, I can see that there is right maxillary sinusitis with fluid densities. I'm trying to scroll through base to the top to look at any base occupying lesion. I can't quite see any obvious lesion.
So what are your findings? What do you think at this point of time? I can give
At
you,
this point,
yeah, I can give you just the bone window. Have a look at the bone window as well.
okay, so okay. I'm trying to scroll through bone window.
Yeah.
Like, okay, yes, I can scroll.
For
I
the
can
sake,
see that
for the,
there is
you can just summarize whatever you're seeing, then we can go to the next imaging. What do you think at this point of time? What are your thoughts?
okay. With at this point, I can see that I saw right right otomastitis and right maxillary sinusitis. I'm thinking this could be a case of a complicated case of venous sinus thrombosis or any.
Okay, you can leave the mouse. You can leave the mouse once.
Sure.
This was the MRI done after 2 days. You can, which sequence do you want?
Or T2 would be nice.
Yep. Oh, okay. I think your
And
time,
flare.
your time is up. Thank you.
Okay.
Yeah.
Okay.
Dave, you can take over.
Yeah, okay. Give me a moment. I'll just put another scores. Yeah, cool. Okay. Yeah, hi. I'll just share my screen quickly. One moment. Can you see the screen?
Yes, I can see.
Yeah. Okay. So your time starts now.
I'm provided with the frontal chest radiograph of a skeletally mature patient. I can see that on the first glance, the bilateral lung volumes are maintained. There is a line in situ. I think this is center line, which is placed appropriately in position at the KO atrial junction. I'm trying to go through my checklist before I'm looking at the lung bases. They appear normal. I don't see any obvious pneumomediastinum. The mediastinum contour is normal. Bilateral aphysis appear normal. However, in my routine practice, I will look at the zoomed up images. I'm trying to look at the mediastinum. I'm suspicious of cleft retrocardiac opacity. In my routine practice, I will look at orthogonal waves as well.
The retrocardiac area is fine.
Okay. Okay. I can see that. I'm trying to look at the bones. Bilateral clavicles appears normal. The right shoulder humerus appear normal. Okay. In the left side, I can't see the scapular outline well defined, and there is a large area of soft tissue in place of it. I've been thinking in terms of whether this is an post-operative patient or urgency of scapula in this patient. I would correlate with the history of this patient and any previous images available from the
Since
childhood.
you asked for the previous image, here you go.
Okay.
And you were right. This is a pre-operative image. Yes.
Okay. Sure. So I'm looking at the left scapula again. I can see that there is a gross soft tissue abnormality with there is a large lesion at the superior end of the spine of the scapula with the internal areas of sclerosis, and there is soft tissue swelling overlying it, and there is also destruction of the underlying scapula. I'm trying to look at clavicle. The clavicle appears normal. I don't see any obvious involvement of the humerus in the post-operative images as well. Okay, so I'm suspecting this is it's an aggressive lesion. In this patient, I would be thinking in terms of osteosarcoma or any Ewing sarcoma. I would correlate with the history of I would correlate with the clinical images. I'm sorry, the clinical reports of the HPE since this is a post-op patient. I'm trying to look at the lung. I don't see any obvious metastasis in osteosarcoma. There would be sclerotic metastasis. So I would convey these findings to the clinician. There is no obvious. Can you please show the post-op images again?
Yes.
Okay. I'm trying to rule out any
I've shown you
metastasis.
I've shown you the pre and post-op images, but what do you think? Did the patient have any other imaging in between?
Yes, patient will have, I think, MRI and
So
CT for
you can take a
staging.
look at the MRI if you want. Here you go. You can ask for control and I'll give it to you.
Okay.
Go ahead. Click once and start scrolling. Yeah.
Okay. These are axial T1 weighted images of the same patient. I can see that. I'm not quite sure of the sequence. I think these are okay T1 weighted images or PD weighted images. Okay. I can see that the left scapula shows a large ill-defined lesion, which is hyperintense and shows some areas of hypointensity within. And this is extending towards the neck and closely abutting the neurovascular bundle. And this is also involving the glenoid. I'm trying to look at the chest wall for any invasion. I'm not, okay, chest wall appears fine. There is no obvious involvement of the ipsilateral lung as well. So this confirms that this is an aggressive lesion for which this operation was done. And I will convey these findings to the subsequent clinician. This patient needs follow-up in the subsequent sittings.
Okay, you can take a look at the next case. Yeah. So this is a 35-year-old female who presented with cough and fever. So just let go of the mouse, please. Thank you.
Sure.
And you can take a look at the case. Yeah.
Okay, I'm provided with the frontal chest radiograph of 35-year-old female who came with the cough and fever history. The first one, I can see that the left lung field shows a very large area of veil opacity involving the upper and mid zones. The bilateral CP angles appear spared. There is also an opacity seen in the right mid zone. I can't quite see the right hot border well. So other than that, there is also obscuration of the left hot border in the upper part. So I'm suspecting infective etiology in this patient. I'm trying to look at other areas, and the apices appear normal. I'm sorry, the right apex appears normal. The left also appears specified. I'm trying to look at any other areas. The visualized abdomen appears normal. There is no evidence of any pneumothorax. There is no evidence of pneumomediastinum. Okay, so with this kind of history, I'll be thinking in terms of infective etiology. I will go over with the lab findings and ask for any history of any occupational exposure. This would be so to conclude, I think this is a case of pneumonia, mainly bacterial pneumonia. I would convey these findings to the referent clinician, and patient should be kept on antibiotics. Also, patient needs to be kept on follow-up for looking at the intermittent changes for any healing or not.
So I'm giving you a follow-up X-ray.
Okay.
This was taken 6 weeks later.
Okay. On the follow-up X-ray, I can see that the previously visualized areas of consolidation are not present. So I think this is healing of the process. I'll convey these findings to the referent clinician, and patient needs to be stopped for any treatment she is kept on.
Okay, here you go. This is the next one.
Okay. I'm provided with the spot images of technetium bone scan and posterior view, I think. I'm not sure. No, this is the anterior view. I'm trying to look at the images. I can see that there are areas of intense uptake. These are geographic, and these involve bilateral predominantly bilateral iliac bones, acetabulum, right bilateral femoral heads and bilateral trochanters. Also, there are areas of involvement involving the ribs anteriorly and bilateral shoulder regions and skull as well and sternum. So in this kind of uptake areas, I'll be suspecting a Paget's disease, and I'll correlate with the X-ray findings in this patient before coming to my diagnosis and ask for history of any previous images that would explain and correlate with the lab values that would show increased alkaline phosphatase. And this patient needs any history. I would also ask for any history of metastasis that would, I'm sorry, any cancer in this patient, because this could also be a metastasis.
Which one do you think is more likely?
I think the Paget's disease will be my top differential.
Why? Why?
Because there is expansion of the bones, involved bones as well.
Are you sure there is expansion? Can you tell based on this study itself?
Okay, I would take back the statement. I would correlate with the findings in the X-ray. So I think this could be metastasis as well. I would correlate with the history of the patient for any primary. They should explain metastatic process in this patient. And I will convey these findings to the clinician. Patient needs a staging CCT, chest and abdomen, look for any primary, what is the cause.
Before we go there, is apart from
Okay.
what you have already described, is there anything else that you see in these images?
Okay, I'm trying to look at the primary if I could find any.
Or if I had to be more accurate, is there anything you can't see in these images?
Okay, I can't see images. I can't see any obvious lung lesion which could give this metastasis. I can't see any breast region uptake. I can't quite see the prostate area because, okay.
Okay, and
okay, I'm sorry. I can't see renal excretion in this. So I'm suspecting this could be superscan, metastatic superscan.
Okay, so we'll just go on to the next one.
Okay.
So this baby presented with breathlessness.
Okay. I'm provided with the chest frontal radiograph of a infant. I can see that on the first glance there is diffuse opacity involving the left lung region, and there is decreased volume. There is also evidence of reticulonodular opacities involving the right lung. I'm trying to assess the age of the patient. I can't see.
Sorry, yeah, go ahead.
It's okay. I can't see the humeral heads. I think this is a premature patient. I will go with the history also. With this kind of appearance, I'm trying to look at hard borders. I can't appreciate the mediastinal contours or hard borders. I am trying to look at any pneumothorax and pneumomediastinum. I don't think obvious pneumomediastinum or pneumothorax are present. Okay. I'm trying to trace the trachea. I can't quite trace the trachea to look at mediastinal shift. I think this could be left mediastinal shift. Other than that, I'm trying to assess the cause of this opacity. In a neonate, I'd be thinking in terms of pulmonary hyperplasia, aplasia.
Okay.
That would explain this finding. Or bronchial atresia in the left side. That would explain these findings. Other than that, any vascular ring causing compression of the left main bronchus, such as left main pulmonary artery originating from the right main pulmonary artery, that would also cause the
Do you
such
expect
appearance.
that? Do you expect that to cause this kind of imaging picture this early in life?
Okay, I would like to take that for statement. Or any external compression can cause this, like any tumor or in the mediastinum, like neuroblastoma. I can't see any obvious calcification in the thoracic region. In my routine practice, I would also correlate with the orthogonal views to look at any mediastinal mass. I would convey these findings immediately to the referring clinician because this patient needs respiratory assistance with the endotracheal tube. Other than that, I'm trying to look at the diaphragm. I can't quite appreciate the diaphragm. I'm trying to trace whether this is a congenital diaphragmatic hernia. I can't see any obvious power loss within the chest. So this is not a congenital diaphragm hernia. So the patient, I would convey the findings and a request for a CECT chest in this
Here you
patient.
go. Ask for control. You wanted CCT chest? Okay, so I just let go of the mouse.
Sure.
I will give you, which window would you like?
Soft tissue window first and then lung window.
Okay.
Okay.
You have control, yeah.
I'm trying to scroll down from top to bottom. Okay. On the first one, I can see that there is shift of mediastinum towards the left side, and the heart appears quite large in this patient. Other than that, I can't see the left lung well. I think this is a left pulmonary aplasia. I'm trying to trace the left main bronchus. Okay. I can't see this left main bronchus. In my routine practice, I will also correlate with the lung windows to look at the left main bronchus and lungs. So I think this is a case of pulmonary aplasia on the left
Time is
side.
up. Time is up.
Yeah, the time is
Okay.
up. Yeah. I couldn't stop the timer because he had control.
Sure.
Yeah, sure. Yeah.
It's still going on. Just give me one moment. Yeah. Okay. Cool. So well done. We'll just quickly go through some of the cases. Wait. So this was the first one. I deliberately started with the post-operative image to sort of make you identify that there is no scapula on the left side. Very well done. I've given you a 7 in this. Yes, you described this pathology. You described the soft tissue lesion, the permeated destructive appearance of the left upper part of the left scapula. And then this showed the same thing. And you've already described your differentials, which was Ewing's or sarcoma. Ewing's sarcoma or osteosarcoma, you described both. But yeah, Ewing's is more likely. I mean, it's a flat bone, and Ewing's is more likely, right? So
Yes.
yeah, this is well done. Your management was fine. You could have mentioned that this you'll recommend that the biopsy be done at bone sarcoma center, because that's where they do all of these cases. They're never done anywhere else. If it's a sarcoma, no matter how good the MSK department is, it's always sent to the bone sarcoma center, which are like 4 or 5 in the entire UK. Okay, then there is the next one. So this was a bit of a tricky case. This is the pathology, and I understand that you mentioned this is a pneumonia in the left upper middle zone, and you described that there is some right lobar pathology as well. But if you look at the post-operative, the follow-up image, you'll notice that there is still some haziness here. So this, the clue lied in the fact that this patient has some amount of pectus excavatum. So this is actually a case of this one is due to the pectus deformity, whereas you can see here, whereas this one is due to the infection, the pneumonia that you described perfectly, but you'll still get 6.5 here because the clinical management and everything did not change because you missed this finding. But this happens a lot. They will show you a case with a complex finding elsewhere in the lung, but there is just an incidental pectus. And if you pick that up, that's like a 0.5 for you, right? So they do that. This one was, yes, you struggled, but eventually you got it. So I'll give you a 5.5 here. This is a super scan. And once you identify the absence of kidney, then the discussion is basically whether you think it's a metabolic super scan or whether it's a metastatic superscan. In this particular case, because the distribution is predominantly in the axial skeleton and the very proximal appendicular skeleton, this is a metastatic superscan. A metabolic superscan, due to anything really, you see a more even distribution of the uptake involving the mid and distal parts of the appendicular skeleton as well. If you look at the pathology here, this was, I believe, what was the cause? They haven't mentioned the cause, but this was a metastatic superscan. This was well done. In fact, you considered the pathology right in the X-ray as well. So yes, there is a little bit of the left bronchus, which you would have seen if you had more time. But given that you started with the axial one, you noted that the left pulmonary artery is absent, and this is a case of left bronchial atresia along with left pulmonary atresia as well. Well done. I'm happy with the way you dealt with the whole thing. Your speed is fine. You give enough opportunities for me or any examiner to sort of ask you questions, interrupt you, but at the same time, your flow is good. Well done. Nikhil, time for you.
Yeah, sure. So I personally feel you're a very solid candidate for a 7, and if you work a little harder on few more cases and adjust your time and stuff, you can easily go in for a 7.58. I understand there are few cases which were tricky, but then you tackled it well. Your approach is good. Your Viva technique is very good. You do not fumble when you're given very tough case or tricky case where you don't know what's happening. The only thing I felt, maybe you can little speed up a bit and wind up cases a little more faster. And so let's start with this
Ma?
first case.
Babi na phone mo lipa.
Sure. Can you mute everybody else? Mute, please. Yep. So this case, you picked up the fractures, but then I was hoping you pick up a lunotricutal coalition here. Are you able to see it?
Okay.
The
Yes,
lunate
yes,
and
yes,
tricutal
yes,
is not
yes.
separately
I
seen.
can see.
So sometimes you get the satisfaction of search and then you tend to miss out the other findings. More often than not, these are very asymptomatic things, but sometimes patient can present with a constant wrist pain, right? So you just give out the fracture and then the pain might still persist a couple of months later. So please look at the bones. I think in the oblique view, even in the frontal view, it was quite apparently seen, isn't it?
Apparently.
Yeah. So that's fine. As long as you picked up the major surgical emergencies, you would pass this case. But if you were to push for a 7, I would recommend that you pick such findings as well. Okay. I think this case, unfortunately, I could not show you all the sequence. Basically, there was a diffusion restriction. You were spot on in the CT. There was, in fact, apart from that, there was a small subdural space in the right frontal region. There was small CS of space. And apart from that, there was diffusion restriction along the cortical margins in the peritoxical region. And later on, DSA was done for the same patient. Patient worsened. And can you tell me what the diagnosis is based on this?
Okay.
Are you there?
Thank you.
Candidate 2?
Sure.
What do you think is happening here? Why am I not seeing any vessels apart from the ICA?
I'm not quite
That's fine.
sure.
That's fine. This is a case of brain death where the complete
brain death.
non-opacive. So later this sometimes you can be directly given a DSA image like this and they can ask you what do you think it is. So this is a case of brain death. All the vessels do not opacify, right? So next, I think I showed you this. I think you did extremely well in this. The PET pickup of the left breast lesion was just too good. And then from there, you told me that there could be a possible breast malignancy, and you picked in the mammography, you picked up the mass, you spoke about the skin thickening, you spoke about the nipple retraction. I was a little upset about the BIRAT scoring that you gave for mammo, but nevertheless, you still considered it malignant, so it's fine. I like the fact that in mammogram, you did mention about BIRATs, and the same goes with ultrasound as well as MRI. Okay. In this case, you could have closed off I think this could be highly malignant this is highly suspicious for malignancy, M5 lesion. I would recommend for MRI and also ultrasound guided biopsy. And later on, I would also look at the dynamic sequence in MRI. Okay. So, and also breast MDT. I'm not sure. Did you talk about breast MDT?
I talked about one-stop reckoning, not MDT.
Yeah, you did not talk about the breast MDT. So please do mention about all the MDTs wherever it sounds relevant. Okay.
Sure.
Yeah. Then I think I asked you something. What was breast? I asked you something. I forgot.
Breast screening and one-stop
Yeah,
bleeding.
breast screening. Breast screening is 50 to 71 years. Okay. It's 50 to 71. The updated guideline is 50 years to 71 years. And like you said, every 3 years. Okay. Next, I think this was a case of a bronchial artery embolization. The first image I showed you was a tortuous bronchial arteries. Okay. And like you said, there was blush, so patient had hemoptysis. The answer I was expecting from you was the artery of Adam Kivish, which can sometimes arise from the right intercostal trunk, right? The anterior spinal can arise from it. So you have to make sure that the anterior spinal artery is not arising from it before embolizing, or the patient can go in for paraplegia.
Fine.
Okay.
Yes.
So when they ask you specific complications, do remember in bronchial artery embolization, this is a very classic question they are expecting you to answer. Okay. Not the contrast allergies. Okay. I
Yes.
think I think all the cases are done, is it? Yeah. So I think personally, I feel you are a very good candidate. So please keep reading what you're doing and keep practicing Viva. And all the very best for your exams. Hope to see you on the other side.
Thank you.
Okay. Yeah. Dave, do you want to add
Yeah,
something?
yeah. Just that we tried bringing more nuclear medicine and a different type of scans in this set. So I'll share the link for the feedback form. So I'll just request everyone to quickly fill up. We'll share it right now.
Sure. Okay. So again, thank you everybody for attending this and hope to see you soon in the coming. We'll update the next session very soon. Okay. Thank you so much. So I think we'll stop now.